Welcome to tonight's Wu University's event, Current Treatment Modalities of Ocular Surface Disease and Glaucoma with Dr. Vin Dang. I'm your host, Dr. Jennifer Stewart. So welcome tonight, Dr. Dang. We can't wait to hear from you. With that, I'll turn it over to you.
Thanks, Dr. Stewart. All right, so thank you, everybody. I know it's always difficult to get everybody to spend an hour to learn about CE, but the beauty about COVID is that we learned that we can learn also online, which is kind of great. Just like what Dr. Stewart was saying, I also wanted to thank Wu University for inviting me. As Dr. Stewart was saying, this is my first time lecturing for you guys, and I'm excited to kind of learn together. And feel free to make sure you ask questions and whatnot. Tonight, what we're going to do is we're going to talk about ocular surface disease and glaucoma and some of the things that are associated with those two disease processes. A little bit about me. Obviously, Dr. Stewart kind of mentioned that I was born and raised in France. I lived there until I was 15 years old. You can't tell from my accent. I'm kind of sad that I don't have the French accent, but I think when I first came to, I moved to Connecticut. So I lived in Middletown, Connecticut. I was made fun of a lot for my accent. So I tried really, really hard not to have an accent. So then the summer before my senior year in high school, we moved out to California, and we landed in a town called Arcadia. And then obviously that's when we've been in California. I went to undergrad at UC San Diego. And then, as you guys know, I went to SCCO before it was before it was Marshall V. Ketchum. I'm currently practicing in Bakersfield, California. I'm in a ODMD practice specializing in ocular surface disease. This is a picture of our office, one where there was a little dog there. I love to travel with my wife and my two boys. Here we are in Hawaii. We're foodies, so we love to eat good food. And if you know me, you know that I love pickleball. So I play quite a bit of pickleball on my downtime. So let's get into it. Tonight, what we're going to do is we're going to talk about some of the ocular surface disease in general. Obviously, we know that it's very, very common. We know that we hear this all the time, how about 20 million people in the United States have dry eye disease. But if you sort of break it down in terms of like blepharitis, about 30 million people have blepharitis. And then if you even break it down into smaller ones, you can see that about 25 million of those people have something called demodex blepharitis. But what about glaucoma, right? Glaucoma, we know it's a usually smaller subsection. We think about 3 million people have glaucoma. But what about glaucoma and dry eyes, right? So what are some of the risk factors? We know that as you get a little bit older, your risk for glaucoma goes up. Same thing with dry eyes, diabetes, right? Inflammation. We know that some of the studies that talk about glaucoma and dry eyes say that as high as 50% of the glaucoma patients have some form of dry eyes, right? When you're looking at SPK, which is one of the signs that's associated with dry eyes, it can be as high as 54%, right? So, I mean, are we as doctors, are we looking at these glaucoma patients, and then are we having this sort of like tunnel vision? Are we focusing on just the glaucoma and not focusing on the ocular surface, right? So those are the type of things that we want you guys to kind of think about when you're treating these patients. What about glaucoma, right? So we know that glaucoma and ocular surface disease, we know that for ocular surface disease, we've always thought about it as sort of like an inflammatory, pathway, right? So when you think of dry eyes, you think about like, okay, inflammation, the vicious cycle and all those things. But what about glaucoma, right? There's some newer evidence that talks about how it could be a disease of neuroinflammation, right? How you have some certain medication that have sort of like this neuroprotective neuroprotection to protect the brain in terms of the oxidative stress or some of the medication that induces more inflammation when we treat the surface. So when we're treating these patients that have glaucoma and dry eyes, maybe we could be treating both of them at the same time. So when we're talking about therapies for ocular surface for glaucoma, right, what is the biggest thing? What do we know is the biggest offender when it comes to glaucoma medication? obviously it's preservative, right? So, and in which of the preservative is the worst? Well, it's going to be BAK, which is the benzalkonium chloride, right? The thing about benzalkonium chloride, though, is that it's cheap, it's very effective, it's very common amongst all of the sort of the generic brands, and that's the reason why a lot of companies like to use benzalkonium chloride because of sort of the properties. Now, how does it work, right? So it usually actually causes this oxidative stress to the trabecular meshwork. And then that causes cell death, which then it causes the elevated IOP, right? So then usually what I do is when I see a lot of patients that are on glaucoma medications, the first thing I'll look at is like, oh, are they on like a preserved medication, right? So the first thing that I'll typically do is that if they're having issues with it, whether it be ocular surface or dryness, or even if their IOP is not responding very well, what I'll do is I'll switch them to a preservative-free medication, right? Because we know that with the BAK, damaging the trabecular meshwork, sometimes even just a simple switch from a preserved medication to a preservative-free medication, you get a better control in terms of the IOP. So we want you guys to be sort of cognizant and mindful of that type of things. What about some of the other preservatives that are out there, right? So you got, the salsias, that's unfortunately only available with Travatan Z, right? But with medication losing the patent, things like that. Now you got Travoprost, that's the generic formulation, right? So then you have to be mindful that when you're prescribing, if you want a different preservative, if you want to try Travatan Z, you actually have to write Travatan Z. Otherwise, the pharmacy will automatically change them to the generic, which is Travoprost. You have something called Purite, which is also available in alpha-GAN P. And the same thing, right? So it's also been around for a long time. And because it's been around for a long time, it's also available in a generic formula. So you have things like Modalities. So if you don't specifically write for alpha-GAN P, the pharmacist will automatically, or the insurance is going to automatically request for you to switch over to the generic, which is then going to be full with BAK. One of the newer one that's on the block is called potassium sorbate, right? So it's what we find in Zelpros. Zelpros, unfortunately, a lot of people think that Zelpros is preservative free, but it's not, right? So it's BAK free, but it's not preservative free. It contains potassium sorbate. So I've had pretty good success with it, but right now, currently, because of some supply chain issues, we've had to take that medication. We haven't been able to prescribe that medication to our patients. So what we do when we're testing for ocular surface diseases, right? So in our office, we do a questionnaire. We specifically like the DEQ5 because of how fast and easy it is to implement into your practice, right? So it's 5 simple questions. I ask us about them within the past month, if they have any issues, if they have these symptoms. And then what I'll do is also I've trained my technician to make sure they, ask him about, do you have any burning, stinging, watery eyes, those type of things. And then I'll go in and follow up and do a very thorough case history. What about point of care testing, right? So the inflammatory, the osmolarity, those type of things. When you talk to, different type of, ocular surface specialists, it's kind of a hot topic in terms of a hot button, right? Some people like it, and then some people don't. I actually fall into that boat of patient that I don't actually like it as much, only because I don't feel like it gives me any more information that I need. So in terms of inflammation, you don't have to have any sort of a test to tell you whether or not there's inflammation. You have a slit lamp in front of you in your office. In that slit lamp, if you have a good examination skills, you can see that there's injection on the conj, and there's this SPK or PEK on the cornea, which is all those are signs of inflammation. And osmolarity for me is kind of the same thing. I'm not a big fan because many different things can affect the osmolarity, right? So so when I have doctors that come up to me and say, hey, what do I need to start my dry eye clinic? What do I need? I tell them it's simple. Get a questionnaire. Use some vital dyes, right? So if you're not using your vital dyes, I highly recommend you use those. Those are the most underrated, easy tools that you have in your office. My biography is great, but it's not a necessity. But it's a huge, huge tool. We've learned that, obviously meibomian gland disease, in the last, 7 to 10 years, it's been a huge factor in how it affects, the ocular surface. And then, just your finger, right? I mean, if you're at the slit lamp, if you don't have to have, a meibomian gland expressor or evaluator, you can just push on the lids and see if anything comes out. This is actually a biography of my own glands, right? So I just kind of wanted to, show you guys that, you got to do what you preach, right? I actually, when I tell my patients about their lipid scans or their myography, I say, hey, yours actually looks better than mine, that way they understand that I can feel their pain and then they can trust us a little bit better. So if you're not doing any of these type of testing, these are some of the things that you could be missing, right? You could be missing residual eye makeup on the eyelashes there. You could be missing some of the blepharitis, specifically demodex here. You could be missing, if you're not staining the ocular surface, you won't be able to see these PEK there, pattern there. If you're not using lissamine green, you're not going to be able to see that, because the thing is that the white light doesn't allow you to see staining on the conch, right? So that's the beauty about lissamine green staining. I love lissamine green staining because it allows me, whenever I see any patients that have no staining on the cornea, their T-bud is pretty good, but then they're still very symptomatic. As soon as I hear that, I go ahead and put on some lissamine green in there, because then I'll be able to see if there's any sort of conch staining, if there's any sort of like lid wiper, or any sort of keratinization, right? Obviously that one was really severe, but here's one that's much more subtle, right? So because it's much more subtle, you gotta pay attention and you gotta look for those things. Obviously, we talked about meibomian gland disease, right? So if you're not pushing on those meibomian glands, you're not going to see what's coming out. You're not going to know whether or not it's clogged, not clogged. Is it like toothpaste or is it oil? And then the third and the final thing is, keratinization, right? So that's a big one. Right? A lot of people don't realize that there's this sort of like keratinized lid margin or hyperkeratinization of the lid margin there. Those are the type of things that you kind of have to be on the lookout for. Here's another big one, right? So it's lag ophthalmos, right? So if you don't know already about the Don Corby, light test, so it's where you use a transilluminator and then you just kind of have them recline in a normal sleeping position. You don't tell them to kind of squint their eyes too hard, because that's not how they sleep. And then you shine the light and you look for any sort of like light leakage, right? In this particular patient, I didn't even have to do that. It was already showing up that I can see the sclera there. Okay, now what we're going to do is we're going to talk about demodex, right? So demodex blepharitis is actually very, very common. There's two types. There's the demodex folicorm, which is the lash inside of the lash follicles, and then you got the demodex brevis, which is inside of the meibomian gland, right? So you have a very, very high correlation with like you see in the picture, in ocular rosacea, right? So you got that inflammation, that telangiectasia of the eyelid margins right there. You've got MGD with the clogged meibomian glands leading to the chalazions and the hordeolum, right? So this is what I was talking about earlier about not needing any sort of point of care testing. You can just use your slit lamp and use your eyes and look at these types of things, because if you don't look at them, you're not going to find them. These are the patient that has like a beginning of a hordeolum. You can see some of that blepharitis there. Same thing right there, another little early hordeolum. Right? Same thing over here. So those are the type of things that they can cause, right? So that we know that the demodex blepharitis is just kind of harboring in the lash follicles, and then if you see that typical collarettes on the base of the eyelashes, that's sort of like the telltale signs. Now let's talk about what are some of the ocular surface diseases that are associated with glaucoma, right? So we know that the K-Zika is a big one, right? With dry syndrome. We talked a little bit about the demodex and the staph blepharitis. You can also have like things like filamentary keratitis or follicular conjunctivitis and conjunctival hyperemia from the side effects of some of the medication, right? So this is the PK here. Here's the demodex. Here's a picture of the filamentary keratitis. Later on, we're going to talk about some of the medications that are associated with causing some of these follicular conjunctivitis there. So you see these like big follicles there, and then the conjunctival hyperemia there. Okay, so those are the type of things that you kind of have to be on the lookout for when you're treating these patients, right? We want you to not just get sort of that tunnel vision where you're like, okay, I gotta focus on taking care of their IOP. How's their IOP? How they're doing? Is there any visual field defects and things like that? You know, most of the time, a lot of us get stuck in this like, okay, I gotta take care of the glaucoma and not worry about anything else. But you know, you're doing your patient harm if you're not, you know, considering some of these issues that are associated with it. So when we talk about medication for glaucoma, what do we get drilled at school, right? When we learn about this, what's the first thing that we like to use, right? The first one is going to be a prostaglandin. And prostaglandins, unfortunately, we know that there are known inflammatory mediators, right? So that's why whenever you have a patient that have some form of uveitis flare up or anything like that, you're going to want to take them off their prostaglandin because it tends to make things worse, right? So we know that the way it works, and you know, it works on the MMPs, and then it basically just kind of works on the extracellular matrix, and it opens up the space, which then causes the aqueous to flow out of the uveoscleral pathway a little bit better, and that's why it works. Now, the reason why we use it is because it's super effective, right? But what about some of the side effects? Well, we obviously know about the more common side effect of, you know, pigmentation around the eyelids and increased lash length and all of that stuff. But what about, you know, this condition that's, you know, been sort of called the sunken eye syndrome, right? This is a picture of a patient of mine who's been on a prostaglandin for years, right? It hasn't been a lot of spotlight on this condition, right? Which is, you know, prostaglandin currently has been sort of nicknamed as PAP, which is prostaglandin-associated periorbitopathy, right? Because what it does is that, you know, they looked at how, you know, it's a very common side effect, right? And the thing is that not a lot of people talk about this. So the prostaglandin also attacks and causes loss of that periorbital fat. And that loss in that periorbital fat is what causes sort of that sunken eye look like you see in this picture, right? So, I mean, we are very, very, you know, okay, yeah, we love our prostaglandin, you know, it's that 30 to 40% IOP reduction and things like that. But, you know, we are harming their patients at the same time because, you know, these are lifelong chronic conditions, right? It's not like we're just going to be doing this for, you know, 1 year, 2 years. It's going to be a lifelong, you know, life sentences, as we call it sometimes. So we want you, you know, I want you to be, you know, mindful and know these types of things. Let's talk about another medication, right? So brimonidine, right? So brimonidine is another big offender because just like we kind of briefly mentioned earlier, you know, the longer you use the brimonidine, you sort of have this issue where the patients, you know, they'll come in and their eyes will be kind of like all bloodshot red. You know, they'll say things like, "Hey doc, you know, it's just like out of nowhere, you know, my eyes are starting getting kind of red, a little itchy, a little watery. And I don't know what happened, what gives, right?" And then you put them behind a slit lamp, and as soon as you put them behind the slit lamp, you see this, and that's when you go like ding, 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 right? So we know that obviously brimonidine is associated with this sort of like follicular reaction, sort of like this allergenic reaction that can cause the development of follicles, right? So in more rare cases, you can have sort of like this granulomatous uveitis, right? So in those instances, what you do is just basically just take them off the medication, and then that'll sort of resolve on its own. What I've typically found was that in my experience, the alpha-GAN P, I don't seem to have as much of this sort of follicular reaction as I do with the generic brands, you know, the brimonidine versions. So something to sort of keep in mind. I know have some patients kind of, you know, doctors also have asked me about, you know, what about Lumify and things like that, since Lumify is sort of a weaker version of brimonidine, right? A diluted version of brimonidine. And my answer has always been that if you have developed an allergy to, the full concentration of brimonidine, you're going to most likely also have some issues, with the Lumify. So that's why you have to be sort of mindful when it comes to that. Okay. What about rho kinase inhibitors, right? So the rho kinase inhibitors, those are sort of like the newer kid on the block, right? So you got the Ropressas, the Rocklatan. Those are the rho kinase inhibitors. So we know that that class of medication causes quite a bit of redness in the eye, right? So I'm sure you've seen your patients, they're just complaining about how like their eyes are kind of reddish. But they also cause this sort of like rural keratopathy, right? So we knew that typically when you see like rural keratopathy or vortex keratopathy, you think of like like amiodarone or certain medications or like hydroxychloroquine or tamoxifen, those type of things. But this rho kinase inhibitors class causes quite a bit of this rural keratopathy, and this is what it kind of sort of looks like, right? But the interesting thing is that I actually had a patient who had been on this rho kinase inhibitor medication for it's probably like 5 years. And then they started complaining about how their vision was starting to decrease, right? So here's a picture of how it looks. You see how much significant, now we know as optometrists that usually, the literature talks about how, vortex keratopathy or world keratopathy is not visually significant. But for this particular patient, I've had actually 2 patients where their world keratopathy was so significant and so central through their central cornea that it actually caused them to be, they're like, I'm kind of feel like I'm looking through like this little bit of this haze and there's this fog. So then in those cases, I actually had to stop the patients from taking that medication. So here is a nice little summary of some of the medication that have the BAK concentrations, right? So just like we talked about in the beginning, we said about how there's so many medications out there and why it's so cheap and so easy, and that's all of the common medications. I went in and put in some of the newer ones there, and I showed you how some of the newer ones also have BAK as sort of their preservative in glaucoma medications. So here's a quick resource for you guys if you don't already have this resource, because you're going to be like, hey, doc, yeah, it's great. You're a lecturer. You can tell me all this stuff. All this stuff, but I'm just Dr. John Smith. I don't know what medication has what preservative. Well, some of our colleagues have created this website called iMeds Now. And the nice thing is it used to be free. Now you have to kind of register. You have to do all the login stuff. But after you logged in, you can use this feature where you can just type in the name of the medication, and then it gives you sort of a breakdown. It tells you what class it is, what its possible MOA, how do you use it. But then if you look down on the bottom here, you'll see that it's, hey, what are some of the preservatives that are associated with it, right? So here I did a little quick search for Zioptan, and you'll see that it's none of the, there's no preservative for Zioptan. If you look for Zalatan, it's benzoyl chloride. If you look for Zalpros, it's potassium sorbate, right? So then this is a nice resource for all of you out there that are like, I'm going to start paying attention, but I'm not going to be able to keep track. Well, this is a nice resource to allow you to kind of look up a medication and see, hey, what medication has what are the preservatives and whatnot. So kind of write that down. Now let's go ahead and talk about some of the options, right? So we obviously talked about the medications that have preservative and how they can harm the surface of the eye. Well, now we're going to talk about the preservative-free option, right? So the newest one that's on the block is called Iuze by Thea Pharma. Iuze is actually just the first commercially available preservative-free latanoprost, which is kind of nice, right? We've always had, we've had the Zalatan, we've had all the other ones, but we've never had a preservative-free latanoprost. Now, if you recall, we've had Zalpros, which is a BAK-free, but not a preservative-free. So if you want a truly preservative-free latanoprost, Iuze is the one. Some of the older ones have been around for a long time, and I sort of put the asterisks on them as Zioptan and preservative-free COSOP. Being that they've been around for such a long time, they're now available in a generic as well, right? So if you're writing a prescription and you don't write a dispense as written, then some of these patients might get the generic version, right? So now it's kind of confusing in terms of your prescribing pattern, because some pharmacy, they automatically switch without even asking. In terms of Temoptic preservative-free Ocudose, that is still the only one that's available in terms of a beta blocker that's preservative-free. So that's by Bausch & Lomb. So here's a picture of iUse. If you haven't seen what it looks like, comes in those single-use files. There's your Tafluplose, right? So that's for the generic version for Zioptin. And then you got the dorzolamide, timolol, maleate, which is the preservative-free COSOP, right? So it is out there, and then your patients might be getting that, but it's because it's still sort of a fairly newer type of medication that's gone generic. It's still going to be quite costly. I don't know about you guys, but my office, my staff, everybody's tired of doing PAs, right? So PAs is sort of like the bane of our existence, especially in the last 2 to 3 years, right? It seems like it's everything you want to prescribe, right? You're saying like, hey, Dr. Dang, you're saying that I need to prescribe a preservative-free, but every time I prescribe a preservative-free option, like the pharmacy comes back, deny, no, you got to give them latanoprost, you got to give them this, right? Well, here's another resource for you guys. It's called irxdirect.com. So what it is that if you say you want to go ahead and start prescribing preservative-free medication, this website basically will provide these two options, which is Zioptin and preservative-free COSOP, to the patient at a fixed rate. And it doesn't matter if they have, Medicare, commercial, whatever it is. What this program does is it works with them and it gives them the medication at a fixed price, right? So I've had a lot of patients where, I've sent their prescription to the pharmacy because they're like adamant about wanting to use their own pharmacy. And then it comes back and they say like, hey doc, I couldn't get that medication. It was like $300. I was like, yeah, remember when we had that discussion and we talked about how there's this other pharmacy that's called Eagle Pharmacy? Well, this Eagle Pharmacy, yeah, you guys should be able to find that in your EMR. You're able to send this prescription there and then they take care of everything. You don't have to worry about, prior authorization. You can even ignore. I tell my staff, go ahead and ignore that denial or that prior authorization request, because I know that Eagle Pharmacy will be able to send it to the patient at a fixed cost. It's usually like $65 a month or something like that, which is reasonable. So this is what it is in my EMR system. It's a pharmacy out in Florida. And then this is what I do. And when I write them the prescription, I write, Zioptin, blah, 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 send it to the pharmacy. And then the patients, basically, they get a phone call from the pharmacy. They take care of all of that stuff on the back end, which is kind of nice. What about SLT, right? We know that SLT has been around for a long time. There's been the LIGHT study, which was done in 2012 to 2014, where they basically looked at how SLT was a safe and alternative option to medication, especially for as a first line of treatment, right? So because of this particular study within our own practice, we now recommend actually SLT as a first line treatment, right? We don't go ahead and go straight to hey, let's put you on a prostaglandin, let's put you on a medication, because of all the things I kind of mentioned earlier. We are mindful about these types of things, okay? And then there was actually update on the LIGHT study and how they sort of looked at the safety and the effectiveness, and they said that it's super good and up to 6 years. And then what it does is ultimately it improved the patient's quality of life, right? It delayed the need for surgery, delayed the need for meds for 3 years, and that's huge for our patients, right? What about MIGS, right? So you have a patient who's got cataracts. Do they have visually significant cataracts? For us, if they got cataracts and it's starting to affect their vision, we say that you're a great candidate for MIGS, right? But the thing is that like there's so many out there. Which one do you recommend, right? So Glaucose eye stent has been sort of like the grandfather, the grandfather of MIGS, right? So they first came out with the L-shaped eye stent, and then they came out with the eye stent inject, and now the latest iteration is the eye stent infinite, which is basically 3 eye stent inject that are at 3 different clock hours. You have these other procedures like the goniotomies, where basically what they're doing is they're removing part of the trabecular meshwork. And the theory is that by removing sort of like that meshwork, you allow the aqueous to flow a little bit better. So there's the Cahook dual blade and the trabectome, which is some of the tools that are used during surgery to help remove some of that trabecular meshwork. And then you got these things like trabeculotomy, which is just kind of like a variation of a goniotomy. So instead of like removing a piece of the trabecular meshwork, they're actually inserting a catheter in there, and then they're sort of like cutting up the trabecular meshwork, right? So they're unroofing the trabecular meshwork, and then they're following that up with a cannuloplasty, which is basically they inject a viscoelastic agent into the Schlemm's canal to basically essentially sort of analogous to like, not only do you change the drain, you also want to unclog the pipes, right? Because if the pipes are clogged, it doesn't matter what you do to the drain, the water is still not going to flow out. Now let's talk about some of the treatment options, right? So you've got the eyelids and all that stuff, right? So here, if you're not looking at the eyelashes, this is what you're seeing, right? So we always talk about eyelash extensions, right? This is some of the pictures of some of my patients with really, really severe blepharitis. And it's just, every time I look at them, I'm always kind of like, oh, and this is the reason why I'm not a big fan of eyelash extension, because they're just, they pay good money for those eyelashes, and they don't want to they don't want to rub the eyelashes because then it's going to fall off, right? But I'm saying, you got to go in there, you got to clean it. If you don't, this is what it's going to look like. Well, what do we recommend, right? Are you still recommending baby shampoo scrubs? Well, if you are, well, welcome to the 21st century here, where we talk about the ophthalmology. They wanted to sort of like clear out some of these myths, and specifically to the anterior segment, right? So, and one of those myths is, should you use baby shampoo as a first line of treatment for blepharitis? So if you are still using baby shampoo as your first line, as your lid scrubs to your patients, I'm going to tell you that that's not a good thing. You're not supposed to anymore, right? The reason why is because, we know that the fragrance is not meant for that. The soap is sort of like a surfactant, right? Because it's a surfactant, what it does is it destabilizes the tear film, and it can also injure the surface. And also in 2004, the American Journal of Contact of Dermatitis named the main ingredient in baby shampoo as the #1 contact allergen of that year, right? So that goes to show you how we are prescribing these diluted baby shampoo because that's what we were taught. But now we have new evidence. We know these new things. So what are some of the alternative options? But for our practice, we use things like Ocular, right? So we got the foam. If you got the patients that loving the wipes, to kind of use them as a makeup wipe, then I'll go ahead and recommend these wipes. We have a friend, a fellow optometrist here, Tanya Gill, who created her own company that calls We Love Eyes, and she actually has a specifically dedicated cleanser and an eyelash brush that you can use. So sometimes for my eyelash extension patients, I'll say, hey, go ahead. If you absolutely must wear eyelash extensions here, make sure you use this stuff. What about demodex, right? We've heard a lot of stuff about how, hypochlorous acid spray, this is the sort of like the OG, like the Avenova, which is the pure. And then you got things like the hydrate and then the optase, right? So really, the differences between the two is really the shelf life, right? Because pure hypochlorous acid is so reactive, it's not very stable, right? So it's kind of like, that's why it comes in a glass bottle, and that's why it comes in an amber bottle. So the lifespan, as soon as you open it for an Avenova, is like about a month and a half, whereas some of the other ones, it's a little bit longer, like 2 years or something like that, right? So just sort of pick your poison. But can you use hypochlorous acid for demodex, right? So my good friend here, Al Kabat, said, nope, you can't. We tried to use the OG cleanser specifically on it, and they found that it wasn't. So what are some of the demodex treatments of the past, right? We know that tea tree oil, right, is kind of like the old school way, but I'm not sure, I don't know about you guys, but I don't know if you ever put tea tree oil in your own eyes. It is gnarly, it burns. That's why it's never, in the past, it's always been sort of like, yeah, you may want to like dilute it with like coconut oil or jojoba oil or something like that, because you can't handle 100% tea tree oil, right? It's very, it burns so much. And then you have things like Claridex wipes, right? So, which is the main, same thing, right? I mean, I used to call these wipes like fire wipes because they're just like, oh my God, as soon as I put them on my eyes, it just like my eyes would be like mentholy, but it'd be burning. And then you got things like, BlephX, right? Which is something that I used to do in the office. But most recently, we sort of like, gone into something called Zest, right? And this is from our very good friend, Dr. Peter Pham, the ophthalmologist. He created this new procedure, which is much more gentle, uses Ocular Shield, the Ocular products, to basically, create this sort of like this foam, and it basically removes all of the stuff without having to use this spinning brush that's sort of what we were using before. But nowadays we have things like demodex, right? So we have this new medication that's loaded lantern ophthalmic solution, and it's great because this has been very, very efficacious. It's an eye drop that you use for about 6 weeks. You put it on the surface of the eye, and then this is how some of the effectiveness for this particular patient. Obviously, they've got that collarettes all around the base of the eyelashes, right? And then this is actually at 3 weeks. So this is not even the full course, but you see the significant improvement with the new demodex treatment now, right? So this is why I don't have to rely so much on using, the Zest or some of the other stuff, because now we have a good tool under our belt to treat this condition. In terms of blepharitis, this is New Lids. If you're not aware of New Lids, it's a sort of an at-home subscription device that you can buy. You just have to be very careful, right? Because I don't prescribe this to my 80-year-old patient who's got dexterity issues, because she's gonna like this is gonna be more like your 40 to 60-year-old that they want to like take care of their own blepharitis. They don't want to really rub. They want to use something cool, and that's what this is for. All right, what about how do we treat the surface, right? OTC tears, you pick your poison. Not even going to talk about that. You got RX medication, and sort of for me, RX medication, I sort of break it down into like the different components, right? For me, I always say, well, the aqueous component, is it the evaporative component, or is it an inflammation, right? We know that in terms of the aqueous component, we got the immunomodulators, right, which is where we've been told the cyclosporins of the world. So there's been so many different iterations of them. They're different concentration, different vehicles. You've got the LFA1 antagonists with the lifitegrast, which is before the cyclosporins, there was nothing else. When lifitegrast came out into the market, it was really, really cool, because a lot of patients, as we know, don't respond to cyclosporin, right? So then it was nice to have something else. Then the newest kid on the block is obviously this evaporative drop that's perfluorohexyl octane, which is 100%. It's been kind of a game changer for me, because it's kind of allowed me to sort of medicate patients on top of what they're already taking to kind of help them. In terms of anti-inflammatory, obviously you've got the low dose steroids, right? Where we always pulsing steroids before you potentially start them on a cyclosporin or immunomodulator. But technically, you have to be mindful that the only medication that is on label is this loteprednol 0.25%, right? So, and that's Isuvis. So technically, Isuvis is the only medication that's on the market for dry eyes, the signs and symptoms of dry eyes, right? So all the other ones, all of those are off label. So sort of keep that in mind when you're prescribing those medications. Here's the newest kid on the block when it comes to the cyclosporin arena. It's called Vivi, which is 0.1%. Here, when I talk about how there's two of them, right? So the other one is the one that's been around for a long time from the infamous pharmacy, which is Clarity C. It's also been, obviously the difference is that they have two different vehicles, right? So one of them is chondroitin, and then the other one is perfluorohexyl butane, which is a semi-fluorinated alkane. What about treatments for neurostimulation, right? So this is sort of like another bucket that I kind of treat in terms of like, ocular surface, right? You've got varenicline, which is, the nice thing about the neurostimulator I like to talk to my patient is that it helps stimulate three different aspects, right? So it's not just like the aqueous component, it's not just the evaporative component. It's kind of like it kind of touches on all three. It touches on the aqueous, touches on the meibomian gland, touches on the mucin, on the conj, which is kind of nice. You got the lesser known iTier 100, which is similar concept, but it's vibrational. Plugs, we obviously love plugs, but we love using intracanalicular plugs. And then you got things like autologous serum eye drops versus PRP. That's been sort of a hot topic. The problem with that is access, right? So for my autologous serum patients, I use a service like Vital Tier that allows me to they take care of everything. I haven't quite found anybody that will do PRP eye drops yet, so I haven't been able to prescribe that. What about in-office treatments, right? So you've got the MGD treating the meibomian glands, right? You got the MeiboFlows, you got the thermal pulsation. Here I am getting my LipiFlow treatments. You've got the tear care of the world, and then the radio frequency. So I sort of lump all of those into like the heating in-office treatments. And then I'm a big fan of the light-based, because of the photobiomodulation. It's sort of like the same thing, the new hot topic, if you're doing IPL, because what it does is it stimulates the mitochondria, which is what photobiomodulation stands for. It basically creates more energy. And then you got something called low-level light therapy, which we recently brought onto our office. Right. So here's a picture of me doing an IPL treatment on a past resident here. I'm kind of treating the cheeks there, and then I'm putting on the adapter and go ahead and treating the eyelids themselves. And then you can see that she has these shields in her eyes. The shields allow me to treat on the eyelids. And then after I do that, I go ahead and do a lid expression. LLLT is basically, red light therapy. And it's basically radiation of red light onto the face for about 30 minutes, which then has sort of a adjunctive treatment that helps enhance the effects of the IPL and basically helps stimulate the meibum as well, stimulate the energy release, skin rejuvenation, and all of that. Amniotic membranes, right? So amniotic membranes is another tool in your toolbox. You got the two types. You got the cryopreserved versus the dehydrated. But what about contraindications, right? So, if you've got a patient who's got a history of any TRABs for your glaucoma patients, so that's strictly contraindicated for your cryopreserved types of membranes because the conj is going to be affected by that ring. And then in your dehydrated membrane, I know that there's so many out there. What I've experienced sometimes is issues with corneal indentations and folds, and this is what I'm talking about, right? So when you got these folds are happening on the surface, and then I've had patients come back on the same day because they're like, oh my God, my eyes hurt so much, and then you got these sort of like linear folds. Right? This is not actually staining, this is actually pooling. But what's happening is that, when we're trying to put something flat on something curved like the cornea, you're gonna always inherently create these sort of folds in the dehydrated membrane. And then these folds then essentially push on the cornea, and then that's what I think is causing sort of these indentations. So then I've sort of like, this new tip, and this sort of goes out to Dr. Ranjit Bajwa. He's sort of, he actually cuts his dehydrated membrane so that way they're sort of like a half moon shape. And that's sort of helps, mitigate some of those indentation. So that's all about the pipeline, right? What are some of the things I'm excited about, what's coming down the pipe? You got Aldera with their Reproxalab. Unfortunately, they got a little bit of a setback back in November. The FDA kind of said they kind of rejected their new drug application because they said that so they're in the process of doing more studies to prove to the FDA that it's effective at controlling inflammation. And the cool thing about it is that it's when you're talking about the inflammatory cascade, all of the things that we've had so far is treating it so more like on the downward, right? But Reproxalab is actually at the on the beginning stages of inflammation, right? So it works on this sort of like reactive oxygen species, the ROS. Another big one that I'm really, really excited about is Azura, right? So the ophthalmic AZR, it's a keratolytic. What it does is it actually supposedly work on the meibomian gland and breaks down that keratinized, like almost like the meibum cap, and it liquefies it. So then it allows, the meibum to kind of come out. And then you got this new company called Aramis that's working on a different immunomodulator. We know that the cyclosporin works on the T cells, but this specific one works on the IL-17, right, which is one of the inflammatory mediator that causes this, dryness and stuff. So here are some of my take-home points. Obviously, we want you guys to think about, hey, don't just be so tunnel-minded when it comes to treatments, right? Think about your preservative-free options, and I've given you some resources. Make sure you look at the eyelids, treat the blepharitis. Don't be like, try to treat everything at once, right? I mean, it's like, if they're here for a vision exam, just get them on the vision exam, get them started on some artificial tears, and have them come back so that way you can do a dry evaluation, do it on the medical side. And the thing is that I have a saying is that dry eyes everywhere, right? Especially in Bakersfield here. I tell people, hey, I don't have to prove that you have dry eyes. You have to prove to me that you don't have dry eyes, because it's like it's so prevalent. And the thing is that if you don't treat dry eyes, send it to a friend, send it to a colleague, and then the patients, they'll be forever grateful for you.